Good evening, everybody. I'm Fanindra, the CEO of Vision 2020 India. So, on behalf of Vision 2020 India and the Divya Jyoti Trust, let me welcome you to this webinar on compliance of a spectacle wear among school children. So, we will run this session for an hour, including the Q&A. And so, Vision 2020 India has been organizing various webinars under its Knowledge Hub initiative. This webinar is yet another very important aspect to bring in quality and setting good practices that our member hospitals can learn and implement at their hospitals. And so coming to the brief context of this session, many of our hospitals, like member hospitals, are engaged in school screening. The school eye health screening programs. It is considered one of the important activities to prevent childhood blindness, and it was observed that the compliance to spectacle wear among school children was very low. So we are spending good amount of resources on this activity, and if the result is not obtained as expected, then the activity needs a reconsideration, definitely. So let us see why are we saying this and what is the basis of it. We'll hear more from our faculty today. And at the end of the day, I think we should be able to understand the issues and the spectacle compliance among the school-going children and the possible actions that we all can take to address such kind of issues. So I'm happy to introduce our today's speaker, Dr. Uday Gaziwala. Dr. Gaziwala is currently the director of Divya Jyoti Trust and is the medical superintendent of Tejas Eye Hospital run by the trust. He's also the co-founder of Divya Jyoti Trust and Ophthalmic Mission Trust, and he completed his MS in ophthalmology from Gujarat University. So he's a member of All India Ophthalmology Society, Delhi Ophthalmology Society, Indian Medical Association, BJ Medical College Alumni Association, Hospital Infection Society of India, and he's also an international member of American Academy of Ophthalmology. So he's considered an expert in the infection control practices. And so he's been really providing a lot of guidance and mentorship on the infection control practice also to many of our hospitals. So he had co-authored several manuals and guidelines. And also he has got several publications in the national journals as well as in international journals and received several awards individually and also from the institution side. So thank you, Dr. Gaziwala sir, for really taking your time and helping our all of us to look at the issues of spectacle wear compliance among the school children.
Thank you, Dr. Panindra. Thanks for the introduction. So we'll talk about this spectacle compliance study. This was an operational research study, and it was sponsored by Vision 2020 Right to Sight India program only. This was done in 2009-10. And it was a multi-centric study with 6 centers participating in the study. Not going too much in details, but as we all know, burden of refractive error among children is very high. And
sir, can I'm just sorry, sir. You could be a little louder, please. Maybe I think we'll come to closer to the mic.
Yeah, sure.
Thank you, sir.
Yeah, sure. So as we all know, the global burden of refractive error is very high among school-going children, and more than 90% of the visual impairment in 5 to 15 age group is due to myopia. Government of India under school health program is trying to address this, not just eye care issues, but also the physical and mental needs of children. And it has been linked with nutrition and counseling also. Preventive and curative services have been provided, and that can give long-term results in terms of improving the maternal and child health program and RCH program also. In terms of implementation of this school screening, 6 to 18 years age group has been covered. That is from 1st to 12th standard. Government and government aided schools have been screened regularly. There's a biannual screening being done. Screening, healthcare, and referral for disease, deficiency, and disability has been an integral part of this school health program. And there's a partnership being expected with school systems in terms of teachers getting involved in screening and communication with the parents. Various models have been used. Some states are using exclusive teams. Some states are doing it in campaign mode. Some state nurses are posted at schools for regular health care of the kids. A mixed approach has also been followed in some states. Involvement of public health infrastructure has also been tried out. And RBSK, we all know, where a complete team is formed to take care of all the health issues among school children. We all know the flow of examination of school eye screening activity. By and large, in the program, it is envisaged that the teacher will do the preliminary screening. But one important thing that I want to highlight here is that the visual acuity cutoff which is used is 6/9. We'll come to this later. We've been performing better and better in terms of school screening and spectacle distribution through the program. But still, a lot needs to be done. Coming to the issue of coverage of refractive error services, there are some issues involved here. Uptake of spectacles is one issue in terms of cost, the perception of need of spectacles, and access to good quality spectacles. The compliance to spectacle wear is also an issue because of the social acceptance being low in some parts, comfort, cosmesis, and perception that spectacle would cause vision to deteriorate among the community have been hindrances. Lack of awareness of the role of refraction and wearing of spectacles for all vision related activities, the awareness is lacking, and lack of awareness of the need for refraction is also there. Over years, it was observed that if a child is prescribed spectacles, there's a peer pressure and the child is called names in the school, which leads to the child not wearing spectacles. Then there's a lack of acceptance of spectacles in the community and even at home. Sometimes it was seen that same color of the frame was given to all the children who required spectacles in the school because the vendor was the same, probably. But that gave an impression of uniformity. And that also created a hindrance. The need for spectacles was not felt many times among children, particularly when the small degrees of refractive errors were prescribed. And that's why the International Center for Eye Health, London, had suggested that we need not prescribe myopia less than 0.75 diopter, hypermetropia less than 2 diopters, and astigmatism less than 0.5 diopter. In rural areas, especially for girls, it is believed that the child with spectacles will not find a match later in life very easily. And sometimes inappropriate refractive error services led to wrong correction, and child will develop a headache, watering, etc., and will not wear spectacles. These were the observations which led us to conduct this study. And what we wanted to study through this was whether parents' education, their occupation, or their economic status had any effect on the compliance, whether there was any delay in provision of the spectacles to the child after the school screening activity was conducted. If the child is not using spectacles, the reasons thereof, which can throw light on what can be done as a corrective measure to improve the compliance, whether the child is aware about the spectacle power and the need for regular yearly examination or not. This was also one of the objectives. This will tell us if our efforts at IEC activities are bearing enough fruits or not. Then the next work objective was whether we are prescribing non-significant refractive errors, and if at all that was the case, if we can suggest to NPCB to issue directive to all the people involved in the activity not to prescribe non-significant refractive errors. One more issue which was not listed previously, but was seen that children were using adult frames. So we wanted to find out whether the type of the frame and the fitting job that was done properly or not. And if it was not proper, then we can focus on the providers to improve the quality of the work. And if the children are wearing adult frames, that definitely needs improvement immediately. So these were the objectives when we set up the study. As I said, it was an operational research study conducted in 2009-10, and 6 centers across the country participated in data collection. So Seva Rural Jhagadia was one, Sadguru Netra Chikitsalaya Chitrakoot was another, Vivekanand Mission Ashram Hospital Chaitanyapur was third, Khairabad Eye Hospital Kanpur, Alaknain Mandir Eye Hospital Udaipur, and Lions NAB Eye Hospital Miraj. These were the 6 centers, and these are the names of the people who were involved in the activity. A technical advisory group was also created, which included myself, Anand Sudan, Dr. Asim Sil, Dr. GVS Murthy sir, Dr. JS Thakur from WHO India office, and Dr. B.R. Shamanna from Hyderabad. We had thought that we'll enroll minimum 200 students at each partner hospital. 6 centers were selected. A study questionnaire was developed and pre-tested. Guideline for implementing the questionnaire was developed, tested, and then shared with the partners, who in turn translated the same into local language. Before collecting the data, a complete list of all the schools with the distance from the hospital was sent to the coordinator, who randomly selected schools to be included in the study, and the selected schools list was sent back to each partner. Questionnaire was administered by ophthalmic assistant or the vision technician to the school-going children from 10 to 14 years age group, class 5 to 9. The ophthalmic assistant who was involved in doing refraction at the schools was not involved in the study intentionally. The supervisor and in charge of the study at each location made sure that the ophthalmic assistant collected data carefully. And this was done by a supervisor visiting another partner hospital while the data collection was in process. So coming to the statistics, totally 162 schools were visited, and there were 982 children, school children, who were enrolled in the survey. Unfortunately, data from Khairabad Eye Hospital came late and could not be used, and that is why I've shown that figure in blue. 982 was barring those numbers from Kanpur. So we had valid data for 970 students, of which SNC Chitrakoot contributed the maximum 22.3%. However, they had to visit more than 19,000 students for this small sample of 217 students. Coming to the observations, 35% of the students had lost their spectacles and did not get a new pair of spectacles. Only 30% students were wearing spectacles at the time of the study questionnaire being implemented. And this indicates very poor utilization of the services offered. There's no difference gender-wise between the enrolled students for the study. How long the spectacle was being used about 60% of the students were using glasses for a year or longer, but this means about 40% were not using it. Distance from the distribution site is not very important, but 62% of the students were residing within 10-kilometer distance from the place of distribution. As I said, age group was from 10 to 14 by and large. That's because we had taken 5th to 9th grade students only. Coming to the source of spectacles, 33% students had received the spectacles from NGO hospitals. 12.9% students had received spectacles from outreach activities, and 22% students had received spectacles from District Blindness Control Society. How long the spectacles were being used during the day? Only 28% students were using the spectacles for the whole day. 35% students were using it for less than 4 hours of the day. That means only when they had to read or write, they'll wear the spectacles. Remaining time, they'll remove the spectacles and not use it. And the other students, almost 40%, were not using spectacles at all. In terms of regularity of usage, 60% students denied regular use of spectacles. And this is a big number. More than 50% students not using spectacles regularly. Upon asking whether they received a new pair of spectacles or not after a year or so, only 22% student had received a new pair of spectacles, which is really very small number. Ideally, all 100% should be going for a repeat exam every year. When we asked them whether they found any advantage of wearing the spectacles or not, 60% students said they felt some advantage in wearing the spectacles. So the other 40% did not find any major advantage. Whether they liked the frame or not, 60% students said they liked their frames, meaning 40% did not like their frames, close to about half of the students wearing spectacles. Where they were going for eye examination, 25% students had gone to government hospital, 38.5% had gone to NGO hospitals, and 13% students had gone to private hospitals. This indicates the need for free services at government and NGO hospitals. To major surprise, almost 25% students were wearing adult frames. Dr. Asim was instrumental in adding this aspect in the study. He insisted that many students were wearing adult frames as per his observation, and it really came out true. Almost 1 out of 4 students who were wearing spectacles were wearing adult frames. Almost 35% students were wearing spectacles with dioptric power less than 0.75 diopter. This is a very important observation. We'll come to this later when we talk about the recommendations. Gender had no impact on the amount of time the child will wear spectacles. Both gender were wearing it for equally long or short, whatever we want to call it, duration. Source of spectacle did affect the regularity somehow. 47.6% students had received spectacles from base hospital, and they were using it regularly. Whereas when it was received from DBCS, only 25% were using it regularly. Coming back to the small degrees of refractive error, so when the power of the spectacle was less than 0.75%, 78.7% students were using it regularly, whereas if it was more than that, almost 85.6% students were using it regularly. Power of spectacles, if it was less than 0.75 diopter, only 24% students were using it for the whole day. Whereas if it was more than 0.75 diopter, 31.7% students were using it for the whole day. There was no statistically significant difference in the power of spectacles against the gender. Both gender were using it equally. Again, relating the length of use of spectacles with the power of spectacles, 50% of the students with the power greater than 0.75 diopter were using it for longer than 1 year, whereas only 16.7% students with less than 0.75 diopter power were using it for longer than 1 year. In routine day-to-day practice also, what we see is that when it is a non-significant refractive error, even adult patients do not want to wear spectacles. So the same finding is being reiterated time and again over here. When the spectacles were procured from base hospitals, 74% students liked the frame. From outreach, 72%, and from DBCS, 43% students liked the frame that they received. One more study was done recently. The one that we are talking about for Vision 2020 was done in 2009-10. Recently, in 2019, we conducted a short study again in South Gujarat. And what we found was similar. Only 50% of the students were complying to the use of spectacles regularly. And when the visual acuity was better than 612, that means non-significant refractive error was being prescribed. Only 34% students were using it regularly. And even when we look at it, monocular visual acuity better than 612, there also very small number of students were complying to the use of spectacles. That means when the non-significant refractive error is prescribed, children, even after almost a difference of 10 years, were not complying to the use of spectacles. And then the major reasons for non-compliance found in the recent study were also similar: broken glasses, broken frames, being teased by friends, called names, lost spectacles, disliked the spectacles, etc. So then coming to the results, all children who were refracted under the school screening program had not received spectacles. We had to go to a large number of students to get the required sample size against the number of children who had undergone refraction. Coverage of school screening activity is not 100% in majority of the areas. Sensitivity of the school administration and teachers is not uniform. In Gujarat, teachers did screening in initial years and later they denied, and then we had to use alternative approaches for preliminary visual acuity screening in schools. Overall percentage of children who are prescribed spectacles at some point of time in school screening activity was found to be only 2.17%. I'm afraid this could be because we have, I mean, this needs to be cross-checked and confirmed, but maybe because we enrolled more students from the rural areas where the prevalence of refractive error is even today on the lower side. This I'm not sure, need to be confirmed. Only 30% students were found wearing spectacles. So 70% of our time, energy, and efforts spent in school screening activity is going waste. There is no difference in prevalence of refractive errors gender-wise. Only 25% students are examined in government set up and have received spectacles from DBCS. 40% students have received their spectacles from NGO hospitals. DBCS is supposed to be providing spectacles free to the students in primary schools up to 8th standard now. Majority of the students in need of spectacles are found in secondary schools. So that's a dichotomy. Only 28% students use the spectacles for the whole day, and only 31% of the students using spectacles regularly. Both things indicate that the resources spent behind the activity are not put to proper use. Only 22% students have gone for a repeat examination to get a new pair of spectacles, and of these, 68% students have gone to the base hospital for a new pair of glasses. This shows that those who are motivated enough to go for a regular eye checkup and get new pair of spectacles are going to the base hospitals rather than waiting for the school cleaning activity. Simply meaning that the awareness is already good among these students. But what about the remaining 78% of the students who have not gone for repeat examination? And this calls for more efforts on IEC activities, particularly making the parents aware about need for yearly regular examination. Nearly 40% students upon questioning told that they did not find any advantage in wearing their spectacles, and we believe largely these were wearing spectacles with power less than 0.75 diopter, non-significant refractive errors. 39% students said that they did not like the frames they were wearing. Either the frames were uncomfortable, big, small, heavy, they did not like the color, etc., etc. About 25% students were wearing adult frames, and this should not happen under any circumstances. How can a child wear an adult frame? It will not stay properly on the face, and the optical center will not remain in front of the pupil. So the power also will remain different, and the child will not be able to see clearly. And naturally, the peer pressure will create more issues for this child. Of the total students wearing spectacles at the time of survey, 34% students were using spectacles with dioptric power less than 0.75 diopter. There was no statistically significant difference gender-wise in the usage of spectacles over a long period of time. When the spectacles were procured from the base hospital, the likelihood of being used regularly were high, 47%, whereas if procured from DBCS, the likelihood of regular usage was only 25%. Need to go in details of the reasons why. When the power of spectacles is more than 0.75 diopter, the chances of the same being used regularly are higher by 10%, which is quite significant, and that is why I'm pointing to this fact repeatedly. Many times the supply of spectacles was delayed by as much as 6 months after the refraction, and in these cases students were losing their interest in getting the spectacles. The delay should be reduced to the minimum possible amount of time. So based on these results and whatever recommendations that I'll talk about just now, this manual was prepared for school screening activity, and the recommendations have been incorporated in this manual. It is available at the office of Vision 2020, the Right to Sight India. So then, coming to the recommendations, we felt that the visual acuity cutoff of 6.9, which is being used presently, should be changed to 6.12 or even 6.18. I don't know if Dr. Praveen Vashisht is with us or not. He had agreed to this suggestion, and just for information, but International Center for IELTS London also says that we can change the cutoff to 618. And this will remove the non-significant refractory errors from being prescribed, which probably are not used or not felt to be very important by the children. The school screening should be done from 5th class onwards. Primary school enrollment is 90%, and those children that are not covered in higher classes due to lower enrollment can be covered later. First 4 grades of students, first to 4th class students, they will not be able to cooperate in visual acuity screening. And very experienced screeners are required to check visual acuity in very young children. And the prevalence of refractive error in the below 9-year age group is very low, and that is why this recommendation. There's no need for primary screening in rural areas. I should not say no need for primary screening, but this should be undertaken only where we have enough resources. And that's because we found the prevalence only to be 2.17%. We should do regular screening where we find the prevalence to be more than 5%. However, this needs to be validated through studies which have larger sample size. We all know that the development of refractive error is directly related with the use of eyes for near work. This has been proved now. So we propose that there is no need to screen the school dropouts. However, this was not a part of the study. This is our belief and included here. But we believe that we should screen students from 5th standard onwards up to 12th standard, and DBCS practical provision should be available up to 12th standard students, because the prevalence of refractive errors increases with increasing age. Myopia develops in the secondary school children more often. Prescribing non-significant refractive errors should come to a stop, and for that the visual acuity cutoff should be changed. Children should be given a choice of different spectacle frames of different colors and different types, so that they are interested in wearing them. Today, children come and ask, I want to wear the frame that Akshay Kumar was wearing in this particular film, or Amir Khan was wearing it in this particular film. So if we give them a choice of different types of frame and colors of the frame, maybe they'll be tempted to use it regularly. And spectacles must be supplied within a short time after refraction. Otherwise, children lose their interest in wearing the spectacles. Emphasizing the IEC activities, I thought will be prudent here. The children and parents should learn about the refractive errors, how to take care of the spectacles, and they should know the importance of wearing eyeglasses as a corrective measure. We need to follow a whole family approach. This will ensure that parents are involved in the activity, and they understand the importance of spectacles, and understand the importance of continuous yearly follow-up examination. To make teachers find this activity interesting, we can consider provision of presbyopic correction for teachers that may attract them towards this activity. This suggestion is based on the apathy of school teachers seen in our area in Gujarat. Promoting healthy school environment can be done at the school level. Identification and referral of common eye complaints of children by the school teacher can be encouraged, and identification of common eye complaints of children, for example, squint or white pupil or nystagmus or abnormal head or face turn, red eye, inability to copy from the blackboard, or any other gross eye abnormality can be taught to the school teachers, and this may help in taking care of the visual impairment among school going children in a better way. So coming to some of the issues that we need to consider for the school screening activity is will the impact of the training of school teachers and ASHA workers get diluted over time? At what interval such training should be repeated to maintain the impact and the interest of the teachers and ASHA workers? Food for thought for everybody, whether we need to screen the non-school going children or not. Treatment in terms of correction of refractive error, particularly for female children who are neglected or the family does not allow them to wear spectacles. This is prevalent even today in some parts of the country. How to motivate the children to go for correction of their refractive errors and to wear spectacles constantly. How to ensure availability of base hospitals either in government sector or in NGO sector with pediatric eye care unit and availability of trained pediatric ophthalmologists in all the districts. I have said taluka level here, but at least at district level, how to ensure all that, and how to ensure more and more involvement of local NGOs, be it even non-eye care, non-healthcare NGO. We can train their workers in preliminary screening and referral. And what kind of financial incentive can be included in school screening for ASHA workers. So these are some of the issues that we can consider for improving the performance of the school eye screening activities. So that was it from the team who did this study. I take this opportunity to thank Vision 2020 Right to Sight India for entrusting us for the study, and I thank all the partners who participated in data collection. I thank Mr. Anand Sudhan for doing the data analysis for this study. Thank you so much, and now it is open for question answers.
Yes, sir. Thank you, sir. Thank you very much. I think really wonderful, sir. This is very elaborative, a lot of data and a lot many issues. Very, I think the presentation is thrown as very good, important issues for to deliberate further. Sir, I've just, before we start the Q&A, I'm requesting participants, please put up your questions in Q&A. We will take it up very quickly. But before anybody asks that, so I'm taking the liberty, sir, to comment on a couple of things. Of course, sir, you already mentioned that 2%, at like 2.17% children only prescribed were given the prescription. That is, I think, a very lowest figure that I have ever come across. I was actually expecting like maybe 40%, like as high as 50%, but it's only 2%. Yes, of course, that figure requires a re-look at it. This was also one important.
Phanindra, it cannot be 40 to 50%. Most of the studies have said maximum 7% prevalence of refractive error among school children.
Okay. Under the age group of 6 to 18.
Correct.
Okay. So, sir, wondering one point was that this study, that Vision 2020 study in 2009 and 10, and the study that you talked about against South Gujarat in 2019, there's a gap of 10 years. In 10 years period, I was really shocked to see the scenario same. with not much of any significant improvements between, over the 10 years period. So that was really, I think, the point that everybody should, I think all of us need to take a note of it, and need to get into the kind of reasons why there are no improvements noted in the same area after a decade of any kind of possible improvement. But without intervention, also I think generally it should pick up something, at least maybe by 10 percentage points increase, by the socioeconomic development patterns. But I'm really surprised to see no improvements in the 10 years period. So all the eye care providers and manufacturers, etc., I think this is a good point to take a note of it.
One possible reason was that even this time we conducted the study only in rural area. We did not go to any large, not even large city, not even a small city. So all these children were from the rural area only. Probably that is the reason why the compliance has still remained the same.
And sir, other point is again 6 months delay in receiving the spectacles. That is also another shocking kind of finding. 6 months delay, I think it's very difficult for any child to wait for it and then expect, the kind of compliance to the spectacle wearing. But I think 6 months, I was actually traveling to one of the states very recently, last week, and I found 6 months, 9 months. I went to CHC, and they said that 9 months it's the waiting time. I'm really shocked. The prescription, the reason they identified was from a CSC, the prescription goes to the Tamil Nadu. From like a Odisha state I'm talking about. Odisha to
Yes.
Tamil Nadu, the prescription goes and then comes back to Odisha. It takes 9 months time. And God knows whether actually the patient by then actually is there or not, and what is the kind of one can expect the compliance coming back and take up the spectacles after 9 months, and the power changes, etc. That's also one of the issue that I think the whole supply chain issue under the free spectacle program is what I think one has to look at it. And so one very basic technical point, you said the visual cutoff, equity cutoff should be changed to 612 or 618, and somebody else was recommending 618. And then the prescription for glasses of a small degrees of refractive error is unnecessary. So wondering that is it because of people not wearing that we are recommending this change, or technically that small degrees of refractive error, that spectacle is not needed to wear?
Well, when the visual acuity is 612, we do not even call it visual impairment.
Okay.
Right.
Okay.
So,
Technically. Okay.
Technically, and so what happens is that these smaller degrees of refractive errors, the correction, the child also does not find so much advantage in wearing that spectacle. So that is what I said, even adults, when they come for examination, if you prescribe them small degree of refractive error, many times they don't even use it.
Yeah, probably that's the reason 40% mentioned that they didn't find any advantage. Probably this is the reason, because they were given the small degrees of refractive error.
That's right.
And then we expect them to study, to wear continuously, regularly is also no point to be noted.
Does not happen.
So it's still one important point that you also brought out, these people not wearing because of a number of reasons, because of it's not comfortable, and they didn't like the color aspect of it, frame they didn't like it, and the weight of the kind of whole spectacle is also issue. But now I think that was like 10 years back, but also for 2019 that you pointed the same thing. But hopefully that now the technology changing, a lot of Indian made glasses are coming up in the country. Hopefully that the eye care manufacturers, particularly in the optical industry, they will take care of these issues. I remember some of the companies coming forward with whose spectacles will be very less weight, and the more designs, more like more frames, etc., with a lot of design. So hopefully people will take the advantage of it. And then those kind of manufacturing manufacturer level initiatives will address certain issues of the issue that he pointed out, like weight issue, and the frame issue, color issue, etc. But now different colors are coming up, different weights, different models are coming up. People choose a range of eyeglasses, particularly manufactured in India, even coming from outside also, they are now look very attractive. So hopefully, I think the eye care manufacturing industry is there's the lesson for them from this presentation, sir. And so let me just look at if there are any Q&A. Somebody is asking questions, sir. I'll probably, Manindita, would you like to take up this question and,
Yes.
facilitate the Q&A process, please? Yes.
Yeah, there is one question.
Yes, there's a question. So I'll read that out for you. After the post-COVID period, the education was shifted to online mode, and children are mostly dependent on the online gadgets for their education. So is the percentage of refraction error cases increasing in the present day?
Well, definitely, yes. Prevalence of myopia has increased, and there are a couple of papers published also recently on this point. As we all know, today today we have proof that use of eyes for near work is directly related with development of refractive error. So in Western world, large number of teenage students develop myopia up to 3 diopters by the time they reach 15, 16 years of age. And the same thing is now happening in India. Myopia prevalence is increasing. So yes, percentage of refractive error because of the use of gadgets for online education definitely is increasing.
And so meanwhile, the other points that 22% only went for repeat examination.
Yes.
I think there's also kind of the counseling effort to be done at the school level. Yeah, so I think there's some reflection coming on this, because large percentage, 78% did not go on their own for the repeat examination after a year, which is actually a must. That's what we promote every year, at least once you go for eye checkup and see. But I think it's only 22%. So what matters was that what last 1 year, 2019 2019, not much of improvement. That's what really shocking. What could be the major aspect that you think, sir, on the major reason behind it? One major reason.
I think because when we conduct school cleaning activity, parents are not around. Even when we hand over the spectacles, I don't think we are inviting parents to come at the time of distribution of the spectacles. So probably the message is not reaching the parents. And that is why I emphasize the need for a whole family approach. At least at some point of time, we should be interacting with parents, and we should be able to convey the message to the parents that a yearly repeat exam is mandatory. Probably this is not happening right now.
Yeah, so I think after the school screening is done, probably children are not they are not carrying forward the message to their parents at home. And as a result, the parents also did not know that their children have been screened for eye examination they went through. And I think there's a gap between the children and to the parents, as you pointed out. But it's Delhi in particular, because I live in Delhi. So Delhi government, they have introduced the PTM, so parent-teacher meeting, once in 6 months or so. But probably that kind of, at least that kind of approach probably needed in other government schools across other states also. That where parents come to know this kind of initiatives taken at the school level. Otherwise, their gap will remain same, will remain forever. I think the loop has to close somehow.
No, you see, as you also said, that the gap between examination and supply of spectacles is huge. And that is where what happens is even the refractive error may have changed by 9 months when the spectacle arrives. So the child will not be able to see clearly with that spectacle which he receives, and then he will not find it interesting to use it. In fact, he may develop even a headache using that spectacle. So we need to look into all these aspects very closely, and because it's a lot of energy, efforts, and resources going into this activity. If it is not bearing the desired fruits, we
Yes.
must be looking at it very critically to make whatever change is required to make this more effective.
Anindita, there is one question if you want to
Yes,
read
sir.
that.
So the next question is, how does one make a child continue to wear spectacles against the background of social issues?
Well, wearing spectacles was a real taboo about 10, 20 years back. Today, that is changing rapidly. More and more students in the same class may be wearing spectacles. So that may indirectly help the student. But we must be able to emphasize that if you use spectacles, you will be able to see clearly at distance, and you'll be able to read whatever is being written by teacher on the blackboard will be seen clearly by you, and that we should show to the child. We should emphasize this point that your vision will be better with spectacles, and that will make the child wear the spectacles. Again, education of parents in use of spectacles, because previously for a female child, when the girl grows up, marriage will become an issue if she is using spectacles. And that is why when this LASIK procedure, the examiner laser, came into market, a lot of girls of marriageable age ran for getting the spectacle power removed. But now with more female students also wearing spectacles, that is becoming less important. So we need to highlight these things to the child, to the teacher, and to the parents. As I said, we have to go for a whole family approach, and whole society should be made aware of the need of spectacles, and that adds to the reason why non-significant refractive errors should not be prescribed, because when we prescribe small degrees of refractive error, we are again creating issue which was probably non-existing for that particular child.
Thank you, sir. I think there's one just comment I'd like to read about it. Somebody says that education about eye to be included in the school curriculum, and the effort by NGOs, may not be binding by it. But the important point, I think, education, yes, to be included about the eye to be included in the school curriculum, at least as a primary, some preliminary aspects of it is really, I think, that's a good idea. Both for the children as well as the parents and the school, everybody will be notified about it. That's a good point. And so, sir, I'm taking a couple of 2 points back home from this session. One is their recommendation, very clear recommendation about visual acuity cutoff change from 6.9 to either 6.12 or 6.18, preferably 6.18. And also the other point is a family-based approach involving the parents. I think these are the two my take points to back to home today from this kind of session. Although it has got a lot of data, a lot many issues it is throwing up. I think one requests more time to deep look at it and understand some more issues from the data that is throwing it to us. So if there are any other questions, please. We are now we reached the time up, like 5 o'clock now.
Somebody
Any other key questions?
PPT. So I'll share the PPT.
Yeah. We will be sharing the PPT, complete video link of the discussion from 4 to 5 p.m. the 1 hour session, including you'll have the link of the audio video link, complete to the video link of the the video session of this webinar. You will be receiving it in a couple of days time. So we can actually keep it for our future purpose, and maybe you can share it with the colleagues whoever could not attend it. That will be a good one. So we will be sharing the link to you, all of you, soon. So if there are no questions, then I would like to conclude the session here. So thank you, sir, Dr. Gajewala, sir, once again, for a really wonderful presentation at your time, sir. Very thrown up, really important issues. We discussed some of the important aspects of it, but I think it requires a lot many this kind of sessions and really understand the data and some more reasons behind why people are behaving like this and why situation did not change in the last 10 years in the same geographical area. And thank you all audience. Thank you, dear member hospitals. Thank you so much.
Bye. Thank you.